Hello everyone. Today in this video, we are going to discuss about the most complicated congenital cyanotic heart disease, that is TAPPC, that means total anomalous pulmonary venous connection. This is the most complicated congenital cyanotic heart disease with increased vasculature into the lung, that means plethoric lung with cyanosis. Second MCQ is this TAPPC is a duct independent cyanotic heart disease. Why this is a duct independent circulation, I will discuss later on. So you have to know that this TAPPC is an duct independent cyanotic heart disease. It is a cyanotic heart disease with plethoric lung. Now, what do you mean by what is the main definition of TAPPC? That means total anomalous pulmonary venous connection. As the name suggests, the pulmonary vein are anomalously getting drained into some other portion with instead of their drain into the normal position. So what do we mean by that? This is normal heart. So this is right atrium, this is right ventricle, this is left atrium, and this is left ventricle. Normally, the deoxygenated blood from the body comes from SVC and IVC and drain into the right atrium. And the deoxygenated blood from the right atrium enter to right ventricle, and from the right ventricle it goes through via the pulmonary artery to the lung. And in lung they are oxygenated, and this oxygenated blood enter into the left atrium via the four pulmonary veins. So this four pulmonary veins drains into left atrium, and from this the oxygenated blood enter into the left ventricle, and from this they are entry into the aorta, and from aorta it goes to body. So that's how the oxygenated blood goes to all the parts of the body. But in total anomalous pulmonary venous connection, these four pulmonary veins are not enter into the left ventricle. Instead of this left atrium. Instead of this, these four veins enter into the right atrium or any major veins of the IVC or SBC via some anomalous connection. That's how these four oxygenated veins blood enter into the right atrium. So there is a mixing of. So what happened? So this all the four oxygenated blood, all the four veins drain into right atrium directly or into the SBC or IVC and then drain into the right atrium. So that's how the oxygenated blood enter into right atrium, and all the deoxygenated blood enter into right atrium, and there is a mixing of all the bloods, and from there is a presence of ASD or PFO, that means patent foramen ovale, and from here from the right atrium the mixed blood enter into the left atrium, and then from the left atrium to left ventricle to aorta. So there is a mixing blood, cyanous blood enter into the body, and that is called total anomalous pulmonary venous connection. So this total anomalous pulmonary venous connection, if all the four veins are drained into right atrium, that is called total. And there is a one other entity is partial, that means partial anomalous pulmonary venous connection, in which not in four veins, instead of four there is either three, two or one vein drain into right atrium, and the left atrium. In a left atrium, suppose two vein enter into the left atrium and two vein enter into the right atrium, or suppose three veins enter into right atrium and one vein enter into left atrium. So this is called partial anomalous pulmonary venous connection. So in this case the amount of cyanosis is less, and in total anomalous the amount of cyanosis is high. In partial anomalous pulmonary venous connection, there is the patient may either present incidentally with cyanosis, or there is a never the patient having any cyanosis. The patient may present with the right heart failure only. So this is partial venous total anomalous pulmonary venous connection, and total it is all the four veins are drained into right atrium via some connections. Anatomy of TAPPC, as I said, in normal, this is the picture. This is the picture in normal heart. So this is SVC, this is IVC. In normal heart, all the deoxygenated blood enter into this area, and the blood from the right atrium enter into the right ventricle, and then from the pulmonary artery and enter into lung, and from the lung there are four major, it is oxygenated, and four major pulmonary veins. This is 1, 2, 3 and 4. These four major pulmonary veins drain the oxygenated blood from the lung into the right left atrium, then the left ventricle, and from this they enter into the aorta. But in case of TAPPC, so this is SBC, this is IBC, and all the four veins. This is the four pulmonary veins: one vein, two vein, three, four. These four veins are getting attached to each other, and this they are produce an illuminated vein, and they drain into directly into the SBC, or they may directly enter into the right atrium, or they may drain into IBC. And the all the oxygenated and deoxygenated blood, there is a mixing is there. So see, the blue is much more, and there is a blue and red mixture, so there is a purple color, and this blood from there they are enter into the right left atrium via the PFO or ASD. So PFO or ASD must be there for the child if the child have to survive either by this ASD or PFO. If this is not there, then child will not survive after the delivery, after the birth. So either ASD or PFO must be there. Why this is the duct independent circulation? Because normally the PDA connection, this is pulmonary artery, this is aorta, and there is a PDA. So in PDA, the blood aorta, this is pulmonary artery. The blood comes from aorta to pulmonary artery. In TAPPC, the child will survive if there is a connection between the right to left hand. When there is a right to left hand is there, the child will survive. Otherwise, the child will not survive. So, in case of if the PDA is there, so there is a left to right shunt is there in PDA. PDA there is a left to right shunt. So, in case of TAPPC, as I said, all the blood mix up in the right atrium. So the oxygenated and deoxygenated blood mix up here, and this oxygenated and deoxygenated blood enter into the left ventricle, and from the left ventricle it goes to the pulmonary artery again, and then to the lung. So small amount of blood enter to aorta and to the body. So there is as there is a oxygenation is on all, as there is a small blood enter into this area. So this is, if we block this, if the PDA is not there, then much more blood enter into the body. So this is, that's why this is the duct independent circulation. If duct is there, the child will die before, the child will die much earlier than if the duct is not, if the duct is not there. So this is, that's why it is duct independent circulation. Now, what are the different types of TAPPC? According to Darling's classifications, these TAPPC are four types. The most common type is supracardiac TAPPC. So supracardiac, that means type 1, that is supracardiac TAPPC. What happens in supracardiac TAPPC? All the four veins, this is type 1. All the four veins, this 1 vein, 2 vein, 3 vein, 4 vein, get attached to each other and produced an illuminated vein. And these vein getting entered to SBC. And from the SBC, it drained into the right atrium. So this is supracardiac TAPPC. Now the second one is cardiac TAPPC. What do you mean by cardiac TAPPC? This is type 2. In this case, the cardiac TAPPC, all the four veins, the 1, 2, 3 and 4, all the veins get attached and drain directly into the heart, right atrium. This is called cardiac TAPPC. Now third is infracardiac TAPPC. What do you mean by infracardiac TAPPC? There is the four veins connect to each other and drain in directly into the IVC, and from there they drain into right atrium. This is called infracardiac TAPPC. And last is mixed type. That means either they mixed with this vein, two veins suppose drain into SBC, two vein drain into IVC, or one vein drain into IVC, one vein into SBC, like this, one vein into the pulmonary artery. This is called mixed type. So these are the four types. Among them, supracardiac is the most common type. This is the most common type, and the supracardiac is always, most of the time, it is non-obstructive. That means there is no obstruction of the blood circulation. But infracardiac type, this is the infracardiac type. It is mostly it is obstructive. That means there is a stenosis is there. So there is a blood is all the blood from the pulmonary vein which is drained into the IVC will not drain properly into the right atrium because there is an obstruction and there is a stenosis. So this is mostly this is obstructive type, and mostly SBC is non-obstructive type. So clinical features is different in obstructive type and different in non-obstructive type. Why? I will discuss in my next slide. So this is obstructive type and this is non-obstructive type. Obstructive type means there is a all the pulmonary vein drained directly, all the pulmonary veins directly into the IVC, and from this IVC the blood enter into the right atrium. So there is a obstruction. As there is a obstruction is there, so small amount of blood enter from the lung to the right atrium, and so small oxygenated blood enter into the right atrium. So there is a small oxygenated blood and much more deoxygenated blood enter into the right atrium. So there is a severe cyanosis. The child is present with severe cyanosis just after birth. Now in unobstructed type, that means when the all the blood enter into deoxygenated blood enter into the right atrium via the SBC, there is a obstruction is less. So in this type, so there is a right atrium getting much more twice the blood from the normal heart. That means from the left atrium, amount of blood which is present into the left atrium in normal heart, it getting enter into the right atrium. So right atrium getting too much more blood, so there is a right ventricular right atrial dilatation, and after that there is a right ventricular getting also dilated, and there is a right ventricular hypertrophy is there. So the child may present with small amount of cyanosis, mild or moderate amount of cyanosis, but the child present with right ventricular failure, heart failure. So why right ventricular heart failure? Because there is a much more blood into the right side of the body, and so that's it. The patient may present with right-sided heart failure mainly. So the clinical presentation is child may present with respiratory distress since birth, as because there is a pulmonary congestion mainly. There is a right-sided heart failure in case of non-obstructive. In case of non-obstructive, there may be a severe pulmonary edema may be there. There may be patient present with right-sided heart failure. Cyanosis since birth. The child may present with cyanosis since birth if there is an obstructive type, and if there is a non-obstructive type, there is a small cyanosis, but the child may present with right heart failure and feeding difficulty because of the right heart failure. So these are the three clinical presentation. In non-obstructive type, the patient mainly present with feeding difficulty with respiratory distress, and in case of obstructive, there is acute emergency. That means patient present with severe cyanosis. Now the chest X-ray. Chest X-ray of TAPBC. The chest X-ray of supracardiac TAPBC, that it is snowman appearance. This is very much important for MCQ. This is snowman or figure of 8 appearance. So this is either snowman or figure of 8 appearance. The head, that means this is the head end. This is the head end is mainly produce of, this is the SBC. This is the SBC shadow, and this is the illuminated vein. This is the vertical portion. This is the horizontal portion of the illuminated vein. So this is the illuminated vein which drain into the SBC, and this is right atrial dilatation. This is right ventricular dilatation is there. So there is the uploading of the apex, and this is look like figure of 8 or snowman appearance in case of supracardiac TBBC, and there is a increased pulmonary vasculature, and so that's why. But in case of infracardiac TBBC, what is seen? It is a oligemic lung is mainly seen. Sorry, plethoric lung is only plethoric lung is seen, but there the child is not present with this type of figure of 8, and there is a cardiomegaly is there. Right-sided heart is getting hypertrophied, but there is a no figure of 8 is seen in case of infracardiac TAPBC. Diagnostic test to diagnose TAPBC is echocardiography. It is the most important and the diagnostic tool, gold standard diagnostic investigation to diagnose TAPBC, and always measure the size of ASD, and always measure the pulmonary artery where it is drained. Now the treatment, as I say, this is the emergency. Infracardiac TAPBC is the acute emergency. In case of infracardiac TAPBC, the child present with severe cyanosis since birth, and infracardiac obstructive type of infracardiac TAPBC, the child is a duct independent circulation, so you need to operate the child as early as possible. The operation of choice is we cut or ligate all the 4 pulmonary vein, and it is we attach with a pulmonary with a left atrium. This is the ligation and closure. We ligate all the 4 pulmonary veins and cut from the either IVC or SBC, and then it drain into the pulmonary, then into the left atrium, and we also close the ASD. So this is the treatment of choice. If the child is feasible for the operation, then we go straight forward acute operation emergency. It is an acute emergency of operation, but if the child is not feasible for the operation, then we need to ECMO. Prognosis is good, 97% survival rate after the surgery, but if we do not do the surgery, the child will die within 6 month of within 6 weeks after the birth. So surgery is the main treatment of choice. If the patient is not getting a surgery, the child will die. Or if the surgery is there, there is a survival rate is very much good. So this is for the TAPPC. Thank you.